In this lecture, we're going to be talking about different types of somatoform disorders. People with somatoform disorders experience body-based or somatic symptoms like pain, nausea, shortness of breath, or headaches. However, while these symptoms resemble or take the form of physical diseases like heart disease, stroke, or infection, their origin is ultimately psychological or behavioral in nature, and there's no objective evidence of medical pathology. For this reason, somatoform disorders all involve the presence of medically unexplained symptoms, such as someone with recurrent chest pains showing no evidence of heart attack on EKG, or someone presenting with sudden onset of muscle weakness showing no signs of stroke on imaging. There are a lot of disorders that feature medically unexplained symptoms, and they could hardly be more different in terms of their underlying cause, prognosis, and treatment considerations. We'll dive into each of these in more detail over the next few minutes. I try to keep this one short and sweet since the semester is wrapping up, but just to give you a lay of the land, we're going to cover a whole bunch, and we are starting with somatic symptom disorder. So, what is somatic symptom disorder? Historically, the starting point for somatic symptom disorder with the mere presence of medically unexplained symptoms. However, because grounding a diagnosis on the absence of an explanation is fundamentally problematic, the diagnosis criteria include a greater focus on maladaptive thoughts, feelings, and behaviors related to the symptoms. The shift in focus is reflected in the current DSM diagnostic criteria, which you can memorize using the mnemonic somatic. So let's go over these criteria one by one. First, the mnemonic will remind you that the somatic symptoms are at the core of this disorder. The specific symptoms involved can range from mild to severe and can involve every organ system in the body with pain, fatigue, headaches, dizziness, stiffness, itching, chest tightness, palpitations, wheezing, shortness of breath, nausea, diarrhea, constipation, and urinary pain all being common. The gastrointestinal tract is the most common location for somatic symptoms, with over 95% of patients experiencing unexplained symptoms in this organ system. In women, gynecologic complaints such as pelvic pain and menstrual irregularity are the second most common symptom. And by over 90% of women with somatoform disorders, the vast majority of patients with persistent stigmatization experience symptoms in multiple organs of the body throughout their life. However, ultimately, only one is required. And the symptoms are either medically unexplained with no physical abnormalities being found, so clearly in excess of what would be expected from any non physical disease that suggests a large psychological component. The next few letters will remind us of the symptoms must be accompanied by maladaptive thoughts, feelings, and behaviors such as anxiety about what the symptom could mean, frequently thinking about the symptom, and lots of time and energy being spent on activities related to the symptoms, such as researching things online for hours each day. And with other mental disorders, the patient must be clearly impaired or distressed by the disorder. Finally, somatic symptom disorder is chronic, lasting for months or years at a time. As mentioned before, symptoms and somatic symptom disorder are genuinely experienced. This contrasts with other conditions such as factitious disorder or malingering, or signs and symptoms are feigned or intentionally induced. However, the line between real and fake symptoms is not always clear cut, and around 20% of people who experience traumatization have intentionally self-induced a disease state or at least one occasion behaviorally. People with medically unexplained symptoms often persist in seeking medical care despite repeated negative examinations and tests. For this reason, people can sometimes incur healthcare costs up to 10 times higher than people who do not, including more primary care appointments or specialist consultations or emergency department visits and more hospital admissions. These patients are also much more likely to be prescribed unnecessary medications and be subjected to invasive tests, procedures, and even surgical operations. People with frequent and severe somatization undergo a median of 8 surgical procedures over their lifetime, with procedures on their urethras and gastrointestinal tract being the most common. These surgeries are much more likely to be diagnostically and therapeutically unhelpful, with over 60% of surgeries and persistent somatization showing no abnormal findings. Because of this, people are higher risk for surgical injuries, including surgical accidents, complications from anesthesia, medications, side effects, and radiation exposure. This makes understanding, preventing, and treating somatization a major personal and public health concern. With that in mind, let's look at data behind the disorder, including who gets it, what happens once they get it, and what forms of treatment are most helpful. First, it's important to recognize that somatization is universal. Every person alive has experienced symptoms of which no cause can be found. In fact, it's believed that up to a third of all primary care visits are for medically unexplained symptoms. For most patients, these symptoms are transient and resolve on their own. However, somatization becomes persistent and leads to distress and dysfunction for the minority of people. These people are said to be suffering from somatoform disorders. The prevalence of somatoform disorders in the general population is about 5%, and that makes it neither as common as disorders like depression and anxiety, nor as rare as disorders like bipolar disorder and schizophrenia. Women are affected vastly more than men, sometimes estimates placing the gender ratio as high as 10 to 1. Persistent somatization begins as early as childhood, and for people with chronic somatoform complaints, this pattern almost always begins before the age of 30. For most people, somatization is a transient phenomenon, which leads to increase around the times of stress. The vast majority improved during follow up, even without treatment. However, for around 20% of people, there were worsening symptoms and increasing anxiety. Because people presenting are often seen in primary care clinics or other non psychiatric settings, treatment is frequently given by providers who have not received specific training in these disorders. In addition, patients with somatoform disorders are quite often hesitant to see mental health providers out of concern that their symptoms will be dismissed as psychosomatic or otherwise not taken seriously. Because of this, somatoform disorders are often trapped in the no man's land between primary care neurologists and other specialists, or asked to see these patients but don't believe that they can help. Psychiatrists who may be more able to help but often won't be seen by the patients. Because of this, treating somatic symptom disorder requires a fundamentally different approach. First, we want to collaborate with all providers, and this is good practice for every client you see. Patients sometimes tend to have many healthcare providers, including multiple specialists in various areas of medicine and psychotherapy. You want to work closely to collaborate with all providers on the patient's team and integrate your findings so that none of you are working in isolation. CBT, or cognitive behavioral therapy, is the best studied treatment for somatization with mild to moderate effects and benefits that are durable, lasting years. Mindfulness based therapies has also been shown to be helpful with similar effectiveness. However, getting patients to buy into the idea that they need these treatments can be difficult, leading to high dropout rates. Antidepressants are the best studied medication treatment for somatic symptom disorder, and evidence suggests that it can be effective. There was a smaller effect compared to CBT. However, the potential benefits must be weighed against the possibility that the medications themselves can cause side effects, which may trigger further somatic symptoms. It's worth being cautious when diagnosing somatic symptom disorder, as there is a high chance of producing negative aspects of diagnosis, such as being highly stigmatizing without delivering much in the way of benefits, as it doesn't really validate the stress when done incorrectly. Telling a patient about the diagnosis of somatoform disorder can significantly damage your therapeutic relationship, especially if it's implied that the problem is all in their head. The best approach to take here is to remember that taking the patient seriously does not always mean taking them literally. However, we should not ignore the pain and distress underlying the somatic symptoms that these patients experience. If you make sure to always take the patient seriously without necessarily taking them literally, you can work on this middle ground between the two extremes. So, we just talked about somatic symptom disorder, which is the disorder featuring medically unexplained symptoms. Next up is a whirlwind tour through the other somatoform disorders, including illness anxiety disorder, conversion disorder, factitious disorder, and malingering. Let's start with illness anxiety disorder, which was formerly called hypochondriasis, although this term has fallen out of favor. While illness anxiety disorder has historically been lumped together with somatoform disorders, the emerging consensus now is that it's more accurately belonging underneath the banner of OCD spectrum disorders. So, what exactly is illness anxiety disorder? At its core, it involves an obsessional preoccupation that one has a medical disease, often something of a very serious nature like cancer. Unlike in somatic symptom disorder, where the client's distress is about the symptoms themselves, in illness anxiety disorder, the client's distress is instead about the belief that they have a disease with symptoms, generally being perceived as merely the manifestations of this disease, such as thinking that a headache must be a symptom of brain cancer. It's a small nuance, but it's important for truly understanding both of these conditions. Luckily, the key words for each are embedded in their names. Somatic symptom disorder is about the symptoms, while illness anxiety disorder is about the illness or disease. The client's belief is that they have a disease that leads them to spend lots of time and energy in compulsive health related behaviors, such as researching the disease online or scanning themselves for signs of the disease, like repeatedly checking for suspicious lumps or taking their own vital signs. While some clients will avoid seeking medical care out of fear for what they'll find, other clients end up frequently going to the hospital or doctor for evaluation and tests. Their healthcare provider will proceed to order a lot of medical tests, but because there's nothing physically wrong, everything will come back negative. And while this might be reassuring for most people, someone with illness anxiety disorder will not only continue to believe that they have a medical disease, but will actually become more dissatisfied and anxious in response to the negative findings. This is because it is just like an OCD. No amount of reassurance will lead to a feeling of knowing that they don't have a disease, and their obsessive thoughts about having a disease will persist no matter how much evidence is presented to the contrary. With clients saying things like, I don't care what the doctors and labs and imaging say, I know that I have cancer. More than just being distressing, this persistent belief can severely disrupt the client's life and lead to significant dysfunction. For example, if a client truly believes that they are seriously ill, they may resign from work or stop seeing family and friends. Furthermore, the behavior related to this belief can potentially put them at risk of medical harm, like side effects from unnecessary medications, scars from exploratory surgeries, or high doses of radiation from repeated x rays. Looking at this pattern, we can see why illness anxiety disorder is best thought as an OCD spectrum disorder. It features the same loop between obsessive thought, in this case, a belief that one has a medical disease, and compulsive behaviors such as checking for signs of the disease over and over that directly lead to distress and dysfunction. Illness anxiety disorder appears to be relatively uncommon, with prevalence around 0.5% of the general population. Like other obsessive compulsive disorders, illness anxiety disorder most commonly begins in early adulthood and is found equally among men and women. Studies on the prognosis of illness anxiety disorder are few and far between, but the data that does exist suggests it's similar to other OCD spectrum disorders and that most cases are chronic and enduring without treatment, with most clients continuing to have symptoms years or even decades into the future. Treatment for illness anxiety disorder consists of CBT as a first line option, as it's very effective with large reductions in both distress and disability. Use of serotonin boosting medication also appears to be helpful. However, both forms of treatment are limited by low rates of engagement, as the client needs to believe that there's a psychological problem at the root of their distress in order for any treatment to be beneficial. Nevertheless, clients who do engage in treatment appear to have much better outcomes. The next stop on our tour of somatoform disorders is conversion disorder, which also goes by the name functional neurologic disorder. You can remember the core features of this diagnosis by thinking of it as can't version disorder, which should help you remember that it involves a clinically unexplained medical abnormality, specifically involving the nervous system, that's sometimes but not always brought on by stressful triggers. The word can't will help you also remember that these clients aren't faking it. They generally can't do the things that they say. They can't even in the absence of objective pathology. So let's look at each part of this definition in more detail. First, the clinically unexplained medical abnormalities can be either subjectively reported symptoms such as blindness or loss of sensation, or they can be objectively observed signs such as slurred speech or tremors. In addition, conversion disorder can involve either the absence of function, as in muscle weakness, or the presence of dysfunction, as in recurrent seizure like activity. Importantly, these abnormalities all involve functions of the nervous system specifically, so a diagnosis of conversion disorder would not be appropriate for a client presenting with abdominal pain or chest discomfort, given that most neurological deficits involve areas that people have voluntary control over. It's easy to conclude that people with conversion disorder are either faking it or just not trying hard enough. However, the can't version disorder will remind us that despite how it may feel to be an outside observer, people with conversion disorder are not faking their disability. Historically, the DSM required that there be a recent stressor in the client's life, with the stressor being the thing that's converted into the neurologic abnormality, such as a client developing leg weakness and becoming unable to walk after their parents are killed in a car crash. However, only about 50% of people with conversion disorder have a recent stressor, so it's no longer required for diagnosis of this disorder, even if it still can be an important diagnostic clue in some cases. While exact statistics on conversion disorder in the general population are lacking, we do know that a third of all new clients seen in neurology clinics have a functional neurological disorder, making it one of the most common reasons that people see a neurologist. The disorder most often affects adolescents and young adults, although cases in both children and elderly have been reported. And there's a large gender gap in conversion disorder, with studies estimating that between 3 and 10 times more women are diagnosed with this condition than men. Conversion disorder actually has a pretty decent prognosis for the neurologic deficit itself. Over 90% of cases resolve within a few days or weeks, and 75% of people never have another episode. However, the prognosis is less good for the client more broadly, as many continue to struggle with other symptoms like depression, anxiety, and interpersonal problems even after the neurologic deficit has resolved. Conversion disorder requires a fundamentally different treatment approach than other somatoform conditions like somatic symptom disorder or illness anxiety disorder, as typical treatments like CBT and antidepressants are not effective here. Instead, treatment should consist of educating the client and their family about the nature of their disorder. When doing so, it's important not to confront the client in any way or imply that they're lying or not trying hard enough, as this is not only inaccurate but counterproductive. Instead, emphasize the lack of objective medical lab or imaging results is good news, and be optimistic that their condition will improve with time. For clients with motor deficits, physical therapy it's been shown to improve functional ability even in the absence of objective neurological pathology. So, referrals to medical doctors, referrals to physical therapists would be important here. Let's finish by talking about factitious disorder and malingering. Unlike the somatoform disorders that we've talked about so far, in which the symptoms and dysfunctions are genuinely experienced by the client, in these conditions, the medically unexplained symptoms are intentionally feigned or exaggerated. This begs the obvious question: why would somebody fake being sick? And the answer to this question is the basis for the distinction between factitious disorder and malingering. In fictitious disorder, which is formally known as Munchausen syndrome, the goal of feigning illness is primary gain, which refers to all of the intangible benefits associated with being sick, such as sympathy and attention. For example, somebody with factitious disorder may feign having severe abdominal pain in order to be admitted to the hospital and receive around the clock care from doctors and nurses and other providers. In some cases, people with factitious disorder will even permit significant disfigurement and disability, such as undergoing multiple invasive surgeries, because they desire to remain in that sick role over and above preserving their own health. In extreme cases, people with factitious disorder may even intentionally harm themselves in order to provide evidence that they truly are sick, with cases being reported of people having injected their own feces into their bloodstream for the purposes of inducing an infection. For clients with factitious disorder, the need to receive attention through the sick role has become so acute that they will go to extreme lengths to maintain it. While all those examples involve the client putting themselves in the sick role for primary gain, known formally as factitious disorder imposed on self, there are cases in which the client puts their child or other dependent person in the sick role, which is known as factitious disorder imposed on another, or formerly Munchausen syndrome by proxy. While the methods are different, the goal is the same: to receive the sympathy and attention that accompanies the sick role. In some cases, the parent may even actively harm their child in order to keep them sick, which is one of the deadliest forms of child abuse that exists and necessitates immediate steps to protect the child. Definitive diagnosis of factitious disorder requires clear evidence that the client is intentionally fabricating their symptoms. However, this cannot always be found, so cases of factitious disorder often end up suspected rather than confirmed. You can use the mnemonic factitious to remember some key patterns suggested of this disorder, including repeat failure of treatments that are often generally effective, in most cases, recurrent presentations for medical evaluation, especially if it involves many different hospitals and clinics. Atypical signs and symptoms that don't match the known pathology of the disorder. Clingy or contentious interactions where the client appears to enjoy being sick or becomes hostile when discussing things like discharging from the hospital. And finally, when the client appears to have a knowledge of their reported illness that goes far beyond what's typical for most clients. However, don't be misled into thinking that you've definitively diagnosed factitious disorder. Because definitive diagnosis is often elusive, it can be difficult to find clear data on factitious disorder. Nevertheless, some patterns have emerged. Factitious disorder is rare, with a prevalence of only 0.1% in the population. However, in acute settings like a hospital, the rate may be tenfold higher, with 1% of clients showing patterns of suggestive of the disorder. People with factitious disorder are typically in their 30s and more often are female. Interestingly, more than 50% of clients with factitious disorder themselves work in the medical field, with nursing being the most common occupation. Many clients with factitious disorder also had a family member with chronic medical condition growing up. Both of these suggest exposure to the dynamics of that sick role play a big part in the development of the disorder. It seems reasonable to try to work with clients who have factitious disorder from the perspective of trying to create a safe and therapeutic alliance while acknowledging that allowing the client to continue in these patterns is likely to result in harm. In contrast to fictitious disorder, where the main draw is that primary gain or all the benefits intrinsic to that sick role, in malingering, the goal is secondary gain or an extrinsic benefit that somebody is getting from being sick, including disability payments, an excuse from work or military service, a lighter sentence in a criminal case, financial compensation for a fake injury, access to drugs like painkillers, or admission to a hospital with its associated food and shelter. Like with fictitious disorder, diagnosing malignant can be hard, as a definitive diagnosis requires clear evidence of fabrication. However, there are a few key clues that will help alert you to the presence of malingering. You can use the mnemonic SHAM, which stands for clear evidence of secondary gain, holes or inconsistencies in the client story, a history of antisocial traits or behaviors, and a pattern of missing medical appointments or treatments that do not directly benefit them. Just like factitious disorder, even if all these clues are here, that's not enough to definitively diagnose malingering, though it still can be strongly suggestive of it. Unlike factitious disorder, malingering is not considered to be a mental disorder, as people will exaggerate, fabricate, or lie for various reasons, many of which are not necessarily related to mental health. For this reason, there is no clear patterns of prognosis associated with malingering, and there's no treatment for it per se. However, it can still be helpful to have a clinical strategy when working with a client that you suspect of malingering. The best approach is to ask open ended questions that cannot be answered with simple yes or no, which avoids providing the client with a roadmap of which symptoms are important and which are not. Most importantly, pay attention to your own emotions. It's easy to get frustrated or even angry when you feel that a client is manipulating or lying to you. And a common reaction is to just try and punish the client or kick them out of treatment. However, ultimately, malingering is a way for clients who have not been able to meet their needs through other means to communicate that they need help. So take a moment to gather your thoughts and process your emotions, and then work out whether there might be a more productive way of helping the client meet their needs. Remember, behavior is communication. What is that person trying to communicate to you? So that's fictitious and malingering. And while I group them together based on the fact that they both involved intentional feigning of illness, they really are two separate conditions that should be considered independently. And that's a wrap for our somatic section. Let me know if you have any questions. It was a pleasure working with all of you this semester. I hope you have a wonderful summer and that practicum and internship are just really, really, really amazing. Bye.